and then the organization that you're affiliated with. Just to make sure that we hear everyone clearly, we invite people to mute your microphone when you're not speaking, and also turn on your camera so that we can get a good engagement from our participants. And of course, you can also use emojis and also the raise hands function if you have questions, or if you want to also give your comments in the presentation. You can also type in your questions in the chat box. No? So we will be going through the questions at the latter part of our webinar. And currently, our session is being translated in various languages. So we have a channel for English, for French, for Khmer, as well as Bahasa Indonesia. And also, let's make sure that it's a safe space for learning. So let's all contribute to that. And also, let's maximize the opportunity by asking questions and also sharing your insights in the webinar. So just to orient you with the translation, so you might want to visit the lower hand of the Zoom room, and then you can see this globe icon here, and then you click it, and then you go to the channel that you're most comfortable engaging on. So we have translators that are doing this currently. So now I invite you to participate in our icebreaker. So we're going to do this a little bit differently as we used to before, because before we used the whiteboard, but now we're going to use and try a new website called Kahoot. So I'm not sure if some of you have already tried Kahoot before, but yeah, so Jeff already placed here the website for Kahoot. So you can just click it, and then you enter the PIN code here. So it's just one PIN code for everyone. And then I'll present another slide. Okay, one moment. So hopefully you're able to enter the Kahoot link. So when you enter the website, you should be able to see this interface. You just enter the game PIN 4232181, and then you also enter your name. So I see Rachel already here. Aldi, you can also use pseudonyms if you're quite shy. So this application will give you some questions that are related to our previous lessons webinars. So if you've been attending several lessons webinars already, so you might be at a disadvantage. All right, so we have also Lady Gaga here with us. Okay, so congratulations on your new album, and I've heard you're going to do a tour. We also have Lorna, Francis. How about the rest? So we are currently 53 in the room, so hopefully all of us can participate in the Kahoot. Please also let me know if you're having challenges entering. But I think it will be fun, because at the end of this short activity, there will be a ranking on who got the highest points. Okay, so we'll wait a few more minutes before I officially start the Kahoot session. Okay, a lot of people still entering. Okay, so for the instructions, you just need to enter this website. You can either use your phone or your desktop browser. Just go to www.kahoot.it. So Jeff already placed the link on the chat, so you can just click it, and then you just need to enter the PIN code. So that's 423181. And then just place your name. Okay, so I think we can start now. So we'll be starting the game now. So you just need to select the correct answer. Okay, so how many lessons have we had so far, including this one? So you have 10 seconds to enter your answers. So just click. Is it 7, 8, 5? Okay, so we have out of the participants that we have, 4 got the correct answer. Actually, 2 answered 6. So the correct answer is 7 because um this includes this current webinar, which is webinar 7. Okay. So hopefully you're getting the hang of it. So for those who are also interested to join, you can still enter the game and also enter the game pin. Okay, next question.
Please keep the number on because sometimes internet interrupt and it has to restart again. So we lose the number.
Yeah, so the number is here at the bottom part of the slide. So that it's 423-2181, and you can also see it on the chat. All right. So we have Lady Gaga as number 1, followed by TH and then Lorna. So as you can see, the faster that you click, the higher the points that you will get. All right. So let's go to the next question. So what's the topic on webinar 3? So is it climate justice and One Health, gender equity, introduction to PPR, or pandemic accord? Okay. No, only one person got the correct answer. So webinar 3.
That was so fast. It was so fast.
That's part of the challenge. You have to be on your feet all the time. So only one got the correct answer. Climate justice and One Health. So we had several presenters share us about this concept. So most of you answered pandemic accord. Actually, pandemic accord is I think the second one with yeah. Okay, next question. Okay, Lorna is already on top, so she's the only one who got the correct answer so far. Okay, next. So these countries have already presented their country implementation report, except with Indonesia, Cameroon, Sierra Leone, or the Philippines. So who did not present so far? Okay, so most of you got it. So the Philippines did not yet present. So we had Indonesia, Cameroon, and Sierra Leone present previously. Okay, so MME Paul is catching up. Lady Gaga still at the second rank. And Lorna has 3 streaks. All right, good. So next question. What does JEE mean? So hopefully everyone will get this right. So it's longer now compared to before. Is it joint exclusive evaluation, joint external evaluation, joint exclusive eradication, or justice external evaluation? Okay. Okay, so most of you got the correct answer. It's joint external evaluation. All right. Next. Oh, we have new people coming in at the leaderboard. So we have Paul and Jegna rising up. Next. What organization is our resource person for lesson 1 affiliated with? So the resource person is Agre Aluso, if you remember, for webinar 1. Okay, so majority got the correct answer. Pandemic Action Network. So that's Agre Aluso from Pandemic Action Network. Okay. So Lorna still on the lead. Second to the last question. All of the countries are members of the Group of Equity during the pandemic treaty negotiations, except who is not part of the Group of Equity. So I think it was webinar 2, which discussed this. who is not part of group of equity? Okay, the correct answer is Vietnam. So Fiji, India, Pakistan are part of the group of equity. Okay, next. Oh, okay. Lorna still on the lead. Paul and TH entering the top 5. Okay, for our last question, according to the UNEP Frontiers 2016 report, what percentage of all emerging infectious diseases are considered zoonotic? So I think this was the presentation from our colleagues from Prezone. So, what percentage? Okay, so most of you got it right. So 75% of all emerging infectious diseases are considered zoonotic. Right, so let's look at the leaderboard, the winners of our session. So at third place is MME Paul. Number 2 is Lady Gaga, and taking the number 1 spot is Lorna with 4,021 points. All right, so congratulations, everyone. So is Lorna a pseudonym, or is it a real person? Or is it you, Olive or Jeff?
Oh, Madam Pool, I am Madam Pool.
Sorry?
Madam Pool is me.
Ah, okay. Who's Lorna?
Oh,
Me.
Congratulations.
Olive,
Yeah. Who's
Olive.
Lady Gaga?
I wonder who.
No one? Okay, so I hope you found that enjoyable. No, so at least it's also a good review for us to see what we've been discussing the past few lessons. So now we go to the serious part. Okay. So just to quickly breeze through, so what lessons is. So it's a platform for us to build the capacity of civil society to engage their governments in pandemic preparedness and response. So we've been doing a series of webinars. So the recordings of the webinars, you can see them in the copper.apcaso.org website. So all of the recordings as well as the write-ups of our webinars can be found on this website. And also, you're free to access the PPR guide for communities. You can also scan this QR code just to see the full document. And then we also have a PPPR training module. So you can scan this QR code for you to access this document. And then for us to contextualize our discussion for today, I would like to invite the coordinator for ACT AP to give us a welcome message. Over to you, Jeff.
Thank you so much, RJ. Hello, everyone, and hello to the 61 participants that we have today. Hopefully, more people will join. Thank you for joining us today, and I'm really very excited for lesson 7. First of all, I hope that you enjoyed the Kahoot. I enjoyed it as much as I do watching. I mean, not hiding from a different name. I'm not gonna say anything more from that. But what's exciting about lesson 7 is for ACTAP and also for which is hosted by Apcaso, given the current climate of the decreasing funding to global health in particular, we are now looking at two scenarios that will sooner or later take place. The first one is the global fund replenishment scenario. There's a huge challenge that is anchored in that particular area. And we need civil society organizations and communities to make sure that we continue to advocate and increase the investment to continue supporting Global Fund, especially in preparation for GC8. The second scenario that we are facing is, given the decreasing funding from bilateral and multilateral partners, one of the ways, especially, and this is coming also from the news articles and the statements from many of the African countries as well, and hopefully Asia Pacific countries would do so, that a major entry point really is to make sure that global health initiatives that are currently being supported externally would be institutionalized in the national health program and within the national health sector of every country. And for PPPR in particular, given this is our major focus, we need to make sure that moving forward to global fund replenishment and through GC8 and moving ahead in preparation for our country's integration of our PPR work, that we are prepared in participating in these two different spaces. And this webinar, this lesson 7, will focus on that. We will talk about what the concept of resilient and sustainable systems for health is. We'll look at that and use that as a framework, and in identifying how we can place pandemic preparedness and response within existing national RSSH frameworks and within the context of the Global Fund. So we'll have a speaker later on who will talk about that. And interestingly, we will also look at a new community guide later, still very relevant to our topic today, which is RSSH. And that is about universal health coverage, another very important area of which we need to focus on. Many countries at the moment are still in the process of establishing their UHC or transforming themselves into a more UHC resilient system. And we'll look at in today's presentation how we can integrate PPPR in that specific area as well. Having said that, let's now move ahead with the presentation. So I'll give the floor back to RJ. Thank you.
Thank you, Jeff, and thank you for emphasizing the context that we are in. So there's a shrinking funding for the development sector, which actually makes us realize the importance of the Global Fund as an institution. And of course, alongside that, we have to look at how the RSSH frameworks actually is relevant to our context, and also linking it to our efforts towards universal health coverage. So for this webinar, we're very lucky because our speaker is actually have worked a long time in terms of RSSH. So our speaker is David Lawrence, Senior Advisor on Pandemic Preparedness and Response at the Global Fund. So he has been in the organization since 2020. And since then, David works in the Resilient and Sustainable Systems for Health, or RSSH and PPR team at the Global Fund, where he provides technical guidance and supports partner engagement on epidemic preparedness and response in the context of health systems and HIV, TB, and malaria investments, including the COVID-19 response mechanism. So David joined the Global Fund after several years at the World Health Organization, spearheading HIV surveillance and strategic information global goods with an emphasis on data use and digital health. So for his academic background, he received a medical doctor degree and a master's degree in public health from Tufts University and a diploma in tropical medicine and hygiene from the London School of Hygiene and Tropical Medicine. He has also trained in internal medicine at the University of Colorado and completed the Epidemic Intelligence Service Fellowship at the US CDC, and was a Peace Corps volunteer in the Czech Republic, where he worked for an environmental NGO. So without further ado, I'd like to introduce our speaker for this session, David Lawrence. Over to you, David.
Thank you so much, RJ. And also wanted to appreciate Jeff's very helpful framing comments. This is an extraordinary time that we're in, and I appreciate the efforts to speak to this moment. I also wanted to really appreciate the Kahoot and the series that you've developed at the Copper Knowledge Hub. It's great to see the kind of the thoughtful build up towards this, and very excited to have the chance to contribute. I do want to, RJ and I were discussing, we would like to keep this as practical and as helpful to the audience as possible. So if you do have any questions that you'd like to get kind of a real-time answer, we're happy to take a break in the presentation and have some discussions on the questions you may have. So without further ado, we can jump into the presentation. RJ, if we could go to the next slide, please. So this quote takes us back a couple of years and really kind of to a different time when the world was coming out of the COVID pandemic. But this quote captures a number of themes that we're going to speak to and explore a bit in this talk. So this is the Global Preparedness Monitoring Board in 2023. Restoring trust will be a long-term exercise and must begin now with the implementation of trust-building measures, including making governance more inclusive, engaging civil society, taking preparedness closer to the populations most in need, and investing in monitoring as the foundation of mutual accountability. Okay, so that's really I think at the essence of this this discussion today. We can go on to the next slide, please, RJ. And here's sort of the elements that we're going to talk about. Again, we have a diverse audience. Some of you are likely expert in RSSH, but we're going to provide a quick perspective on that and then get into some of the more detailed information around how Global Fund has integrated pandemic preparedness in response into this RSSH kind of portfolio, inclusive of the community system strengthening, and then turn to really the most interesting and important question here, which is what civil society can do more to support RSSH initiatives. And then we will talk about, in the end, we'll look at some specific ideas about opportunities for strengthening and expanding community engagement in RSSH and PPR. So with that, we will go, if we could, to the next, right? We can go right ahead, RJ. Okay, so I have two kind of overview slides, and this again this may be familiar to you, but at the bottom you have our grant cycles, grant cycle 5, 6, and 7, which is the cycle that we're in now. And the takeaway here, as you can see by the arrow, you know, the funding that the Global Fund has provided to countries to support health systems has almost doubled from the 5th grant cycle to the current one. Now, a lot of this is due to the so-called COVID-19 response mechanism, or C19RM, which I'm sure you've heard about before. But nonetheless, the funding that has been provided to countries is unprecedented, and we're going to look at some of the results and what's kind of extraordinary about that. I wanted to call out, you'll see on the lower left these two terms, contributory versus direct, and I think the names are somewhat self-explanatory, if you will. We're not going to spend too much time on them, but we're going to focus more on the direct financing, which is to say investments in the more horizontal health systems that are contributing to HIV, TB, and malaria responses. We can go to the next slide, RJ, thanks. Okay, so really to kind of set the tone, I wanted to provide this slide, which really tries to summarize a lot of the outputs and outcomes, and in different ways impact of the last year of implementation. So this is really sort of the products of 2024 investments. And you can see this impressive evidence that we've been able to support countries to deliver results at scale across community health worker programs, digital health investments, medical oxygen, waste management, infection prevention and control, and a number of other areas. So really, really impressive, just numbers wise, and that's quite new. We haven't had these types of data to provide in the past, so it's been exciting to see. Next slide. So we're going to start to kind of go into more detail now. Go right to the next slide, RJ. And this slide is sort of still kind of at a portfolio level, but it starts to give you a little bit more granularity. On the left side, and these are data that summarize the available funding in this period, which includes C19RM and the core grants. So on the left side, you get the country investment, and you can see the proportionate size. There are no surprises there for those of you that know the global fund model. And on the right side, you can see the breakdown by these program areas or these investment areas. And these are all kind of reflected, kind of formally in what's in the scope of global fund grants. And you also see this broken out by the funding source. So in blue, you've got our core grants, HIV, TB, malaria grants, and RSSH. And then in green, you see the C19RM. And it is interesting to note the variability. In some cases, you see almost entirely funding from one or the other source. In other cases, it's mixed. Next slide, please.
Hi, David. Some of our
Okay, yeah.
Sorry.
Thanks, RJ. I saw I saw the note, and I will slow down. Thank you for thanks for the heads up. Okay, so in the next few slides, we're going to go into a bit more depth in 2 or 3 of these investment areas, these health systems domains. And we really want to, again, kind of provide color context to how Global Fund has demonstrated that these health systems or RSSH investments have been supporting HIV, TB, malaria outcomes, broader system strengthening, and sustainability. And you'll see in the examples, we're gonna look at some country examples, how there have been clear contributions to the HIV, TB, malaria programs and to PPR. And then we're also going to, you'll see some examples of where we've been able to demonstrate progress within a maturity model or maturity framework where the system's capacities have been progressed. And also, I think one of the themes is the fact that with the current investments that the countries are implementing, there is a considerable amount of infrastructure, what we kind of refer to as capital expenditure, but it's laying the groundwork for countries to be able to maintain systems and public health functions with more efficiently, with less of that intensive cost. Okay, so RJ, we can go to the next slide. So we wanted to start with this example that is on human resources for health, including community health workers. And you can see the very large investment across a wide number of countries. And there's a significant proportion, about a third, that's come from the C19RM. And these examples you'll see in a number of countries, but here featuring Indonesia, where there's been an expansion of the polyvalent community health worker workforce. In a number of countries, there have been expansions through blended training initiatives of integrated services, including HIV, TB, malaria, and maternal and child health, reproductive maternal child health, and then a number of other examples, many examples where assessments have been done to look at the specific status of community health worker programs, which are going to lay the foundation for more strategic investments going forward, including in the next cycle. Next slide, please. So this is the profile on the community system strengthening investments. Again, very sizable amount across almost 100 countries, close to half of it coming in from C19RM. And in these country examples that you'll see on the right, some really nice examples of community-led monitoring, and communities playing a direct role in the accountability mechanisms and helping to ensure continuity of service delivery and avoidance of stockouts of key commodities, et cetera, et cetera. So some very, very nice examples that have been described there. And then if we could, RJ, I think we'll go, the next slide, I believe, is laboratory. I think for the sake of time, because these slides will be made available, we'll go to the next slide, which is a little bit more specifically, PPR focused. Here we have the surveillance system strengthening. Again, these are unprecedented investments from a quantitative standpoint in a large number of countries. Now, most of these investments have come through C19RM. There have been some really exciting examples. We haven't seen this before at this scale. A number of countries that have been able to train workforce to support responses to new emerging outbreaks. And then several countries, including one we're going to talk more about in more depth shortly, that have established and actually scaled up community event-based surveillance, and a number of other some expansion of digital tools, and some really other nice examples related to Mpox response across sub-Saharan Africa. So that said, RJ, I think we can kind of slowly move through the next few slides. I don't think we have time to go through all of them, but there's some nice examples here in health information systems, including, and then when we just keep going, RJ, here, health product and waste management systems. Again, here you see a lot on the infrastructure side, and that we know is going to be really important in this current moment that we're in, and the information systems, the ability to monitor supply chain from central down to depot and facility and community levels. Next slide. And then medical oxygen and respiratory care, where there has been a predominant focus on the ability to for health facilities to produce oxygen that will then provide the life-saving treatment to everybody from neonates to older populations. So next slide, RJ. Okay, so now we're going to turn to this key question, which is some ideas on strengthening, expanding role of civil society in RSSH and PPR. So this slide is a busy one, but the crux of it is, I think it helps to acknowledge right up front that thinking about how to engage health systems, RSSH, PPR, is different. With HIV, TB, malaria across all Global Fund eligible countries, at this point in time, there are typically clear targets, if you will, for whether it's for advocacy, for focusing on policy issues, for thinking about implementation roles, or for monitoring and accountability. And that could be obviously like the National HIV Control Program. It can be the National AIDS Commission or the CCM, and a number of other community fora. But there are kind of fit for purpose governance models. Now, with health systems, what you see here is a graphic that kind of shows the different frameworks that many countries are thinking about. These are WHO frameworks. There are essential public health functions. There are these international health regulation capacities. And then you have the building blocks on the right. Now, they're all kind of interconnected, but how these end up being translated into kind of governance structures in a country and a health sector varies quite a lot. And you can get strengths and weaknesses and comparative advantages that really need to be thought through when civil society and community organizations are starting to think about how to do more. So we can move to the next slide. So this is just a really simple and really intuitive kind of stepwise approach to, thinking about, first of all, what are there's so much complexity, but what are the policy and the programmatic priorities? And in some cases, this is going to be, what are the specific public health functions? What are the IHR capacities? What are the health systems that communities are seeing as most important at this moment? And then how is the governance structurally represented? Where is it? What are the fora? What are the units within a health sector, whether formal or informal, that are important, that are relevant? And then using that to really think about establishing a targeted community engagement. And again, where, as we've already discussed, the key message, the intuition, the sensibility is that any health sector, health systems and PPR goals can only be achieved by including communities end to end. This is from governance through the operational processes and planning, and direct implementation and oversight roles. So with that said, next slide. What we're going to do here, and there's so many different frameworks, and we could spend hours and days kind of talking about these, but for those of you that may not have seen this before, this is one of the latest kind of way that WHO is trying to promote member states and countries and communities to think about health emergency preparedness and response. This is the HEPR framework. So what they've done is they've taken the IHRs, kind of consolidated it into these 5 subsystems. And then on the right side, you see the enablers. So I thought we'd use this just because it's convenient. We could use any of these frameworks, but to look at a couple examples. So if we could go to the next slide, please. So across these 5 subsystems, I'm going to call out here what their WHO is referring to as emergency coordination and collaborative surveillance down below, which is where we find community-based surveillance. Now, under emergency coordination, in the planning and coordination, the prior webinars have clearly laid the foundation for this by talking about the national action plans for health security. Those are used oftentimes as the basis for proposals to the pandemic fund and to global fund. And then, the JEE, the SPAR, the after action reviews, simulation exercises, all of these tools that countries have been using to strengthen capacities and to pressure test capabilities. And then we'll talk a little bit more about this community-based surveillance as a particular example. So next slide, please.
Yeah, David, probably before we proceed, there's this question from Mornay Foleyan.
Yep.
Maybe Mornay, can you unmute so that you can share your question?
Thank you very much, David. I think this is really brilliant and very helpful. Sadly, this is my first time on the call. I wish I could get the past recording. But if we could go back to that slide where you looked at engaging RSSH and PPR. Yeah, excellent. So I'm thinking, it seems complicated, but when we are looking forward to planning integrations between the HSS building blocks as well as the IHR core capacities by state, and we want to use the CLM as a point of entry for making this happen, and then recognizing that in the country, IHR core capacity issues is being implemented by different government agency, health systems is by different government agency. Do you have examples of how that integration has seemingly happened? Thank you. Over.
Yes, thank you so much for that question. Excellent question. And I hope that the next few slides and the example that we're going to talk through is going to actually help to answer that question. And so maybe we can, if it's okay with you, we'll come back to that after we've walked through these slides, and we can talk more about that.
Excellent. That's good.
Thank
you.
Yeah. Okay, so So again, we're coming from the last slide. We identified emergency coordination, which is broad. It's preparedness and response. It's planning and coordination, and it's and we're going to look at collaborative surveillance and community-based surveillance. So for the Global Fund, one of the things that's been very exciting in the past couple of years is some of the innovations around our implementation arrangements, where for the first time in some countries or in other countries where we've had, say, some limited kind of contacts with some of the directorates for health systems and or some of the institutes like National Public Health Institutes that work alongside ministries of health that provide a lot of essential leadership in health systems and PPR. We've engaged them more directly as implementing partners and in some cases subrecipients. And that's been really interesting to see that evolution. So if we could go to the next slide. Now we're gonna talk in more depth, and I think we're gonna come back to the question from our colleague about specific opportunities and applying kind of these context-specific tactical approaches. So every country is different, and not all countries have national public health institutes, but we have national public health institutes, but we have seen them increase in all regions around the world, and including in sub-Saharan Africa. And this is an example from Zambia. ZNPHI is relatively new, and for me anyway, is we've thought about Global Fund programming in Zambia, both from our core grants and C19, thinking about the organizational structure of ZNPHI has been very insightful. Okay, now I want to try and speak to that without getting into too much detail. Here at the bottom, you see these 6 essential kind of functional clusters. You have surveillance, you have preparedness and response, including outbreak response. You have lab, you have information management, strategic planning. You have this one PHPDC, which is policy, it's diplomacy, it's partner coordination, including community engagement. And you have field epidemiology. And up above, you've got public relations, AMR, and One Health coordination, which is, I would just call out is really the interface with other sectors, for ZNPHI. Now, in thinking about, community and civil society roles. So first and foremost, it's pretty clear that the entry point for engaging ZNPHI would be this PHPDC cluster. And they are very progressive at seeking to engage communities and to be engaged by communities, and to do so in a holistic way. And sometimes that involves facilitating cross-cluster discussions and coordination. So we're going to talk a little bit about an example now where the area of community-based surveillance brings in multiple clusters from surveillance, from pandemic or epidemic preparedness and response, and SPIM, the information management, as well as FETP. And you could even say One Health. Okay, so it's an entry point, PHPDC, and an issue that is functional, that is about implementation and direct roles and responsibilities, and also a part of accountability and monitoring. So, okay, if we could go to the next slide. So this is again, all of these slides we could spend dedicated sessions talking about, but some of you have probably heard of the 717 timeliness metric. It's been now adopted by WHO, and many countries are also adopting it in their local context. Essentially, it's a timeliness metric. We've never had these before. It's a very simple concept, but essentially it allows countries to really understand the performance of how they're detecting new events or new outbreaks, how they're verifying them, and then how they're responding to them. So you can see here, Zambia, in a number of outbreaks that they use this kind of analysis to assess their performance, they had a kind of a mixed performance over these different areas, and clearly some room for improvement, particularly in the detection and response areas. So next slide. Okay, so this is how ZNPHI, as they've been sort of on the cutting edge of employing 717. And this slide really reflects their early observations about how critical community-based volunteers have been in implementing 717 within these so-called early action reviews. You've had an outbreak and you're assessing what worked in detection, in verification, and in response. Next slide. And specifically, they've looked at the roles of these community actors in event-based surveillance, which we spoke of, but also indicator-based surveillance. And those are really the two pillars of early warning surveillance in countries, which is one of the arguably the most essential IHR capacity. And it's also reflected in these other frameworks that we've been speaking of. Next slide. You can just progress this all the way through, RJ. So this is, this to me is really a money slide. I think we lost the title somehow. Sorry about that. But this is really the event-based surveillance model that Zambia has been implementing, and you can see the fundamental, the very natural and the intuitive roles for identifying signals. And in Zambia, they have 7 specific signals that have been identified as priority. And you can see the fundamental role of communities and the community-based volunteers and the community health assistants that are living and working in communities who are involved with the signal reporting, and then how that moves up into the health facilities or potentially sub-district or district level type authorities who are working hand in hand with the community-based volunteers and with communities to deal with the signal, essentially to verify, determine if it's a real event, and then if appropriate to respond. Next slide, please. This is just a picture of a couple of the tools. You've got a digital tool and a paper tool that have been developed for this specific initiative. Next slide. And then also from ZNPHI, a nice example of a specific outbreak in measles outbreak in the Zambia context, and where they really describe just how vital the community and the community-based volunteers played a role in early detection of this, which allowed successful containment of a measles outbreak. It was not without loss of life, to be clear, but the measles outbreaks can be quite widespread and devastating, as the U.S. is experiencing right now. And the community-based volunteers and the roles of the community were seen as vital to mitigating morbidity and mortality from the outbreak. Next slide. So again, again, more on how ZNPHI views the community-based volunteers and the community health assistance as really essential to the system, okay, to the early warning surveillance system, and contributing, again, functionally in the implementation of the system and in the monitoring and the accountability for that system. So those two things go, pardon me, really hand in hand. Next slide. And then, and I want to say this is almost the last slide, but this is from ZNPHI again, more on how they view the benefits of this community participatory surveillance and response approach, these roles that have to do with faster reporting and verification, improving the local awareness, and that gets us closer to issues of trust, and then the sustainability. So next slide. And I think I hope, RJ, we're doing okay on time. But I wanted to finish with these 4 takeaways. So what I'm hoping you'll have drawn from the presentation so far is that Global Fund has convincingly demonstrated that it can help countries to design, invest in, and to implement health systems and PPR investments. Secondly, these areas are complex and they're very different, oftentimes in HIV, TB, and malaria, but they can and they must be engaged and supported by communities to ensure success. That is a complete no-brainer. And there are practical approaches that include conceiving of these end-to-end roles from policy and planning through advocacy, implementation, monitoring, accountability. And the most important thing is where we started, which is that in this moment, the moment that Jeff described at the start of this, trust matters more than ever. And community voices are going to be key to ensure that the health systems are resilient, to ensure that the capacities are there, but the capabilities are there. Without community voices involved with every part of health systems and PPR, the enterprise, it's not going to go well the next time, and that includes in the moment before us today. So, RJ, I'll stop there, and I'm happy to go back to the earlier question or in any other direction that you'd like to go at this point. Thank you.
Yeah. Thank you, David, for that comprehensive presentation. So there's a lot to take in actually with that presentation, but I hope everyone was able to get concepts and also be inspired with some of the work that different countries have been doing, supported by the Global Fund. So probably before we proceed to addressing some of the questions, I would just like to check in if the one raising their hand has a question, or is it a legacy hand or an old hand? Okay, so probably you can just confirm that later. But okay, so I see Peter raising his hand, so maybe we can take that one question before we move to the next part of our session. Go ahead, Peter.
Thank you very much. My name is Peter Owiti. I work with communities in Makueni. That's in
Peter? Is it just my internet?
Yeah, it broke up.
along the northern and the government from this side has also surveillance of diseases presentation and how it works. Can you hear me?
Sorry,
Yeah,
Peter, it's broken up. Can you repeat?
Yeah, I'm saying I'm very impressed with the way the presentation has been made, and I've attended many meetings on this one. But unfortunately, we have MPOX coming up, and I am aware of the JEE. I'm aware of the Kenya National Public Health Institute established in Kenya, and we have also medical countermeasures being implemented, but they never come where the disease is. We have MPOX coming in, our community are suffering. We don't have that tool that you are talking about. On the presentation looks very impressive, but the ground things are different completely. And I think the community is being left out to respond to this good function that health emergencies start from communities and end with communities, and it's not happening.
Should I come in,
But
RJ?
the structure looks very good, and that's where.
Yeah, so I think Peter is concerned.
How do we make the communities, all these resources being spread around? That's my question.
So, thanks, Peter. I first of all, I want to acknowledge that there are obviously massive challenges to achieving this vision in almost all countries. It's not easy anywhere, but I think there are some examples that shed light on opportunities. Zambia is just one where in the past several outbreaks, including MPOX, the communities and the community-based volunteers are truly viewed by these public health authorities, these PPR authorities, as the essential frontline workforce. And in this community event-based surveillance modality, because it's so effective, and the nice thing is that the 717 is providing data, and it's really where you can show within those analyses how the communities and community-based volunteers or community health workers, how they're contributing to the most essential public health function in PPR. That is early detection, rapid response. You know, you see the pathway to using data. The data is showing the invaluable contributions, direct implementation roles of communities, and it is also linked to advocacy, accountability, because it's a performance measure that you can follow over time, and it's going to allow communities increasingly to hold governments to account for the resources that they're using, right? So I don't discount country to country, and I haven't worked in Kenya for some time. I have a lot of respect. It's a complex place from a governance standpoint. Almost all incident management structures or teams include a community engagement pillar, a risk communication community engagement pillar, because it's a WHO standard feature. In any context, my first intuition would be find out the name of the person or the people who are leading that committee, that pillar group, that working group, get their names, get their contacts, and reach out to them and start that way, because that, as in that example I gave of the ZMPHI, there's a plate. You look at that complex organizational chart, but there's a place where it's a soft spot, if you will, because they're oriented to community voices, and they're seeking to engage. And so when you target in that way, I think there are likely to be opportunities. But I do not. I'm not suggesting that it's easy or straightforward in a lot of countries.
All right, thank you, David. I think two messages, no? So one is we have to find our champions inside these institutions, and then second, we have to be strategic as part of civil society in terms of engaging the government. All right, so probably we might need to proceed first with the next presentation. But before that, I'd like to give a last chance to CNPUD if they want to ask their question. So kindly unmute if you have a question. Okay, so if not, you can also type it on the chat if you're having challenges with the internet connection. But for now, I'd like to turn the virtual stage over to Rachel Otto Amponsa, the coordinator for ACT Africa, to present us the compendium of community guides that you have prepared. Over to you, Rachel.
Thank you very much, RJ. Good morning, good afternoon, good evening, depending on where you're joining from. I hope you can hear me clearly, RJ.
Yeah, all good.
Yes. Okay, so David, that was a very good presentation. It was very insightful. And for me, what is running in my mind is for our country partners, having this information, how do we align it to the work we are doing in our respective countries? And so I think you should be thinking around this area. But first of all, I'm noting that there are new people on the call today, and it'll be good to give them a little background of what we are doing, what COPPA is about, so that it can align with the webinar. So if you're new here, COPPA CE basically means Community Engagement in Pandemic Preparedness and Response. This project is being funded by the Global Fund and is currently being implemented in 2 regions. So it's being implemented in Asia Pacific and then in the Africa region. So for Asia Pacific, the region working on this is APCASO ACT AP. And then if you come to Africa, it's the African Coalition on TB. So that is where I work. So this COPPA project is being implemented in 8 countries, 5 from the African region, and then 3 in Asia Pacific. So in Africa, we are working in Kenya, Cameroon, Liberia, Sierra Leone, and what's the other country? Kenya, Cameroon, Sierra Leone, Nigeria, yes. And so what we are seeking to do with this, and for the Asia Pacific country, we are working in Indonesia, Philippines, and then the Cambodia. So what we are seeking to do with Copper CE basically is to influence PPR policies at the various country level. How do we go about this? We first of all have undergone training for various civil society organizations, communities on pandemic preparedness and response. Because for you to even influence PPR policies at the country level, you need to know what you're talking about. So PPR trainings have been conducted at the various countries. Also, the countries have come up with advocacy agendas, basically for them to know what they are going to speak about. And so one source of in providing information to our country partners and to civil society organizations as a whole is this compendium of community guides on pandemic preparedness and response. So if you didn't join our last webinar, which is the webinar 6, we launched our compendium of community guides, which is made up of various community guides on PPR on different thematic areas. So currently, this compendium contains a community guide on PPR. So PPR itself, it gives a broad overview of what PPR is, how its usefulness for community, civil society organizations, even local leaders. We also have a community guide on gender equality and human rights and PPR. There's a community guide on PPR and antimicrobial resistance. There's a community guide on the pandemic accord. If you've never heard of the pandemic accord, this guide will be very useful to you to enable you know what is happening at the global level and to advocate accordingly. For today, we are adding on to this compendium. We are adding a compendium or a community guide on universal health coverage and PPR. And so we have the consultants who worked on this guide to basically take us through why the guide is useful, why it is important, why should we use this guide. Next slide, please. We have more community guides coming up. We'll be having one on climate justice and PPR. We'll be having one on the broader work being conducted by the Global Fund around HIV, TB, and malaria. So the learning around that's those things, and then pandemic preparedness. We'll also be having a community guide on engaging in JEE, NAPS, and then the SPA processes at the country level. And then for the last 3, we'll be having community guides from the Copper CLM team who will be providing us with these guides. I must say that also from the country works that is going on, they'll also be coming up with community guides, which will be adding on to the compendium. And so the compendium is going to be a very useful tool for everybody. RJ, if you can share the link to the compendium in the box and next slide. So you can access the compendium here on the Act Africa website. You can scan to take you directly to the compendium page. Next slide. If you do not want to go through all the hassle and bustle of going through all the compendium, RJ, next slide, the last slide, please. If you do not want to go through all the hassle and bustle of going through the whole entire compendium directly, we've made accessible to the guides you want to download directly. So if you want, for example, the community guide on gender, you just have to click and download. The link has been shared in the chat box. And so I'll hand over to RJ to introduce the consultant who will be giving us an overview of the community guide on universal health coverage and PPR. Thank you very much, and over.
Thank you so much, Rachel, for walking us through the different community guides and what will be the community guides that are still yet to be released. So for now, I'd like to turn the virtual stage over to Fitsum Laco. He currently works with the WACI Health as the liaison manager to the African Union Commission and coordinates the African Civil Society Platform for Health. So he was the consultant who developed the community guide for UHC. So I'd like to turn the stage over to him. Please go ahead, Fitsum.
Thank you very much, RJ. I believe I'm audible. So as RJ introduced, my name is Fitsum Lako. I work with Waki Health as the African Union Liaison Manager. I also coordinate CISPA, the African Civil Society Platform for Health, which is more of a non-state actor convener in the dialogues at AU, UN level, and also other regional and national spaces. So to give you a bit of a context on how we kind of developed the guide on community guide on UHC, and also looking on PPPR, whereby how universal health coverage can also be instrumental in addressing. Okay, I'll do my best. So yeah, sorry for losing the thoughts pattern. On how universal health coverage also can further strengthen PPR response. So just to give you some facts, especially on our status with regards to the actual scenario of universal health, especially looking into that UHC 2030 target. So it's obvious that we are off track. And with the current pace, which unlikely that will make it to 2030 based on the agreed indicators, benchmarks, also with the context of 2030. So looking also again on the UH Service Coverage Index, which looks into the overall performance of countries. It's a WHO index, which looks into the overall performance of countries with regards to their UHC progress. We had kind of got a lot of gain between 2000 and 2021. However, given the last few years, the index coverage has only made progress 3 points as index increase, and looking into some of the elements, we are a bit far lagging behind. And in fact, looking into the post-pandemic era, there has almost not been any index improvement. Looking into the proportion of population covered with essential health coverage services, we have around 4.5 billion people who are not fully covered with essential health services or basic health services. We still have 2 billion people who are facing financial hardship, and 1 billion people are experiencing catastrophic out-of-pocket expenditure. And from that, around 344 million people are going into extreme poverty due to health cost. As a result of COVID-19 pandemic, 92% of countries have reported disruption in essential health service delivery. And after 2021, we still have 84 countries who have again reported there is disruption. So according to WHO, to gain what we have lost, especially post-COVID, we need to very much reorient health systems to focus on primary health coverage. By doing so, we will make sure that 90% of UH interventions can also be addressed, which can save up to 60 million lives. So this is the context and the background against which we developed the guide. Next slide, please. Thank you. So this is the guide layout. We have the definition of terminologies. We have the overall UHC status and the relevant policy frameworks, continental, especially looking into the WHO and also country progresses. We looked into existing policies, strategies, and also commitments on UHC. Sorry about for the background noise. And also looking into how a resource is being allocated and what kind of resource modalities are in place, and also what kind of matching political commitments also support the resource allocations. The other one is, and very important, is to look into how PPPR is also integrated into UHC, which is very critical especially for communities to further understand that. Then we look into how communities and civil society engagement mechanism in UHC and PPR decision-making processes are also very important, and how communities also can participate on those. And also finally, conclusion and recommendation to further strengthen communities and civil society engagement in UHC and also PPR. Next slide, please. So I would like to bring your attention to this diagram. This is basically what we call the UHC service coverage, UHC cube, whereby it looks into 3 dimensions of universal health coverage. One is looking into the financial protection, which very much looks into what people have to pay and very much answers the out-of-pocket expenditure. The other dimension is service, what services are covered for the prices that communities are paying, be it out of pocket or through community-based health insurance system or such. And also the other dimension is population, which looks into who is covered within that. So within the overall, the bigger cube, you have the coverage mechanism, whereby on the illustration, you can kind of understand that to address or to have a fully functioning universal health coverage, the inner cube needs to stretch to the other dimensions or to the other extremes of the UHC cube. By making so, we have to be very systematic in a way that we don't disrupt one dimension of the cube while we're doing so. So maybe, for example, if we are increasing, if we are kind of addressing the financial protection and making sure that communities are covered and out-of-pocket expenditure is very low, then we have to be very sure that we are not disrupting populations who are being covered in there, because now we are minimizing cost, then definitely population covered might be affected because we are investing a lot. And also this might also have some implication on the services, because we have to make sure that services are also available and kind of the technologies that we need are in place. So just by focusing maybe on out-of-pocket expenditure, there is a high risk of also addressing negatively the other 2 cubes. So we need a very systematic approach in terms of bringing universal health coverage. So this will give us or kind of provide another approach to universal health coverage. Then what should be the game that we should play or we should follow? What should be the strategy? So as much as we need to achieve universal health coverage in all our health programs, we need also to apply universality in every of our interventions. So it can be PPR, it can be PHC, any intervention that we're applying. We need also to be mindful of the universal health coverage cube lens, whereby what we do in the different programs also have this approach of making sure that out-of-pocket expenditure is low, services are also well provided with the quality, and also populations covered within that without any discrimination are part of those programs. So as much as universal coverage can be the broader picture that we're trying to achieve, at most, we need also to make sure that the principles of universal health coverage, especially the cube lens, should also be addressed in each of our interventions. Next slide, please. So I think this will also give us a more of comprehensive kind of understanding to what PPR should be. So as you can see on the diagrams, we have the 4 different circles, the prevention, the control, the protection, and the response. These are the basic elements of pandemic prevention and response. And to make sure that communities are well involved and coordinated, we need also communities to be part of the different elements in the response. So for the prevention, communities should be part of the planning phase, the planning stages. So make sure that communities have access when government and any other responder on ground, it can be regional, it can be WHO, Africa CDC, doing the prevention plan, there should be also element of community participation. When we're doing controlling, it's very, very much, we're talking about technicalities, we're talking about health system responses, we're talking about also the facilities. Then we need also to train communities and also civil society members, so that the training can also help them to organize and make sure that then we go to the next stage of protection, which leads into how we are equipped, and also we are well oriented with the different stages of exercise. So within the prevention, control, and protection, also in terms of early detection and such, then the overall response. So this cycle is very important for communities. 1, we understand them, and 2, that we participate in every stages. And for that, we need more of a multi-sectoral approach to it. It's not just an advocacy approach that we need, but more so an approach whereby communities are very much oriented and meaningfully participate in these conversations. Next slide, please. So then how can we integrate a PPR into UHC? So on the UHC Cube lens, I've kind of touched it in a way. So how can we integrate PPR into UHC? So it's basically going back to the slide, to the diagram which I presented earlier, whereby we need a universal approach to each of our programs. So we need to be very conscious and aware that we need to apply those principles: equity, affordability, access, and make sure that people are not discriminated when getting services, and making sure that the universality element of it, being accessible, equity-based, is something that we need to approach. So making sure that everybody understands that pandemics harm progress towards universal health coverage and can erode the years of efforts and gains that we have put into place. And COVID-19 is a very good example for that. UHC principles are very crucial for a successful response to health crisis. And definitely we have also understood that, especially during the UHC, during the COVID pandemic. Then finally, UHC should also include a full spectrum of public health services and functions. So this is also what we're trying to address, like the vice versa approach of it. Like UHC is something that we need also to introduce. The principles need to be introduced in every programs that we have in the health system. Next slide, please. Then the next slide looks into how communities can also participate in universal health coverage. I think where we are very strong and we have been very successful so far is in advocacy, but it should not be limited to that alone, because advocacy then definitely should give us the space and the reason and the experience also to participate in the other areas. I think it's network issues. Someone saying they cannot read the slide, but I think we can share with you, and it's also available on the compendium. So in addition to advocacy, we need also to make sure that we participate in service delivery. It might not be directly providing the services, but supporting the service delivery program in terms of detection, in terms of creating awareness and making sure that communities are aware of their rights and demand those services. And then that definitely will lead to accountability and also to quality of services. The other one is participatory based research. I think we cannot overemphasize this. At the end of the day, the real beneficiaries of all our health programs are communities, and communities, it's all of us. So unless we participate in terms of the need assessments, unless we participate in the overall approach of our health programs, then definitely we have missed the real need. We are not really addressing the basic underlying problems and challenges. So communities need to participate in all of the planning stages, starting from also what we say research phase. Then community financing. This one is a bit tricky, and we need also to be very strategic about it. Let me use that word. Whereby we often hear approaches of community, of PPP, public-private partnerships, often not really including communities as one of the custodians. So there is also a new approach, not a new approach, but a terminology that introduces communities in the equation. So PP, public, private, and community partnerships. I think it's PPCP, whereby communities should very much participate in most of our PPP engagements, public-private partnerships. Oftentimes, we have what we call corporate social responsibilities, which private sectors, alongside government institutions, provide those services for communities. But usually, we see this being part of a report at the end of the year, or something that both government or maybe the private sector can report on in terms of providing support to the communities. However, if communities are part of the research initially, if communities are part of the service delivery, starting from actually delivering services to the awareness and demand creation, if communities are part of also what we call the advocacy approaches, definitely the community financing will have a justifiable approach to it, whereby the demands are very much quantifiable, the demands are very much well explained, and from there we can also cost the demands and see how public, private, and community partnerships also can take over that. So very much looking into also ensuring domestic resource mobilization also plays a key role within that. Next slide, please. So as a conclusion, we have suggested the following. So communities need to be empowered with the knowledge and with the right understanding to make sure that they participate and fully gain what they rightly deserve. We need to undertake wide spread of sensitization of community and also public functions, whereby also communities are part of this sensitizations and very much also promotes the essence and the importance of community engagement in providing quality services moving forward. We need also very much to understand respective country contexts. This is very much also very important. Oftentimes, we tend to forget in terms of contextualizing the needs at community level, not just at national level. We need also to be very much aware of the different programs and approaches we have at national, regional, and global level, so also communities can mobilize themselves and provide inputs that needed to address policymakers. Mobilize and capacitate professional champions, community leaders, and such, whereby everybody is oriented of the demands, the needs, and also the way forward, moving forward. And also invest in research and community-led monitoring, align the respective programming to HC and PPR commitments. And finally, also to be part of a community monitoring program, whereby communities are able to also to independently analyze, assess, and provide critique to the different health programs that we run. Thank you very much.
All right. Thank you, Fitsum, for that presentation. And I think you did a good job in terms of explaining some of the frameworks that support UHC. Why do we need to actually push for UHC? And also gave us some very helpful recommendations at the end. And I can see there are some questions already posted on the chat. So I'm sure a lot of the participants were very interested with your presentation. But for now, I'd like to invite also David in our virtual floor so that we can already proceed to the Q&A. David? All right. Hello. So probably just to get the ball rolling in terms of the discussion on RSSH as well as UHC, maybe David, can you, since some of our participants are just first time attendees to our webinar, so they haven't heard of RSSH before, so maybe you can start with explaining in simple terms what RSSH actually mean. Because earlier you presented some evidence, also some frameworks about it, but maybe we can go back to that so that we can tie it with the discussion on UHC.
Sure. Thanks, RJ. So probably the most practical way of thinking about RSSH, and RSSH is a Global Fund, I think, recognized several years ago that the traditional conceptions of health systems were deficient, were lacking. And so it built on those and it customized them and built them out deliberately to reflect both health and community systems. And I think that's really key. And then the domain of community system strengthening within that. But conventionally speaking, okay, particularly where the Global Fund, when it was established, was helping to support country responses that were largely verticalized responses, and where there's a recognition that there are horizontal systems and platforms that have been in existence for decades and that are still vital, even where they've, if you will, been in certain ways customized, verticalized, intensified, right? And we see at this moment right now that again, Jeff spoke of very poignantly, that countries are now reflecting. I don't know if you've seen the recent policy analysis from the Kenyan government, just came out in the past 24 hours. But in that analysis, they're really doing a stock take of the foundational horizontal systems upon which health services are delivered. So that's a supply chain system. That's your workforce, including your community workforce, pre-service and in-service training. It's the data systems that allow clients and patients and programs to be monitored effectively and appropriately and become the basis for CLM type initiatives oftentimes. So that's probably the simplest way, RJ, in my mind, to talk about RSSH. Thanks.
All right. So I guess the attendees now have a level of understanding on RSSH, which enriched your presentation earlier. So probably I'd like to go to this question posted on the chat. Someone is asking, some countries have delimited the development of NAPs from civil society and communities. Can Global Fund advocate through the RSSH module opening these spaces for civil society? So maybe it's a question for David.
Sorry, RJ. I was just actually reading a couple of the questions and comments in the chat. Could you repeat that? I had thought you were going to go to somebody else, so my bad.
No, I was trying to read through the questions chronologically, so it's an old question. But yeah, so the question said, some countries have delimited the development of NAPs from civil society and communities. So can Global Fund advocate through RSSH module opening these spaces for civil society?
This is a tricky one. You know, all of the donors and technical agencies have limitations in terms of how far they can go. To take the question to the fullest extreme, it would be stating that as a requirement, where we can set requirements for a country coordinating mechanism, because that is a fit for purpose global fund governance body. But where we would be extending that to what is essentially a country governance body. I believe that even constituencies within our board that are representing communities and civil society would represent that as an overreach for a multilateral donor like the Global Fund. And we do fall back on the principle of country ownership, even though we know that, like, again, I'll state this as an American, oftentimes you fundamentally disagree with what your government's doing. There's still a government there that's kind of in the lead. So I can say more there, RJ, but I'll stop for now. Thanks.
So it's a possible policy option, but there might be challenges in terms of its implementation. All right. There's this question by Harry Alpha. Harry, would you like to ask this question live, or would you want me to read your question? Harry? Okay, so I'll just read it now. So he says, thanks for the brilliant presentation, David and Copper CLM team in Apcaso. So his question is how the Global Fund can support countries to develop tools to track all of these strategies. I really want to know more about the 717 theorem, but this is a strategic presentation and it would be adaptable with Global Fund early support to develop tools and relevant TA to support this.
Thanks very much for the question. So one very specific point of progress that I can mention here is that Global Fund has included indicators and work plan tracking measures within the performance framework of C19RM, specific to 717. So it is using and this has to do with more the adoption of 717, right? The application of it, which is a WHO recommendation, which is, of course, our kind of gold standard for member state guidance. But we have gone to the point of actually introducing it into our performance framework. And so where countries have related investments in early warning surveillance, it can be related workforce, related laboratory, community system strengthening, that they are encouraged to include this indicator within their performance framework. And it gives us, as Global Fund, and it gives all the partners of the Global Fund a basis for understanding how those investments are supporting this very critical performance area. Thanks.
All right. Thanks, David. I see Lizzie raising her hand, so we can just give her the space first and then...
Yeah, sure. Can you hear me?
Yeah. Go ahead.
Great. I mean, lovely conversations and discussions, and I like the aspect of bringing in UHC. So Fitsum, was a great presentation. I'm more concerned about what's going on right now, and we're looking at, the funding landscape, the US pulling out, but we were also in the middle of a pandemic treaty. And I don't know how that kind of intertwines with the discussion that we're having today. So are we going to have a pandemic treaty end of May? And definitely, if that's the case, it's going to affect a lot of programs and a lot of integration work of PPR into global fund programming. Is that something that GF is already looking at and already just kind of reading the landscape and seeing how that ball game is going to go?
Thanks for your question, Lucy. That's a complicated one. That's we might say above all of our pay grades. We've been tracking. We at the Global Fund have been tracking the pandemic treaty, pandemic accord negotiations for the last 3 years very closely. We've been in the meetings as observers, and we've looked at every point of progress. It's hard to imagine, even where the pandemic treaty comes out as in an optimal state. Okay, and we can talk more about what optimal is here, but one of the most essential issues has been around pathogen access and benefit sharing. For those of you that have tracked this, and that point within the negotiations has really led to the breakdown in negotiations again and again, and it's quite classically a global north, global south kind of divide. But I think even in a scenario where the pandemic accord is ratified at the World Health Assembly in May, and it's in a great place where we would all look at that and say it's about as good as it could be. I don't think anyone expects that the financing aspects of the pandemic accord, first of all, would be binding, and that they would necessarily supersede any of the bilateral official development assistance conversations that are happening around the world, from Asia, through Africa, the Middle East, Europe, North America, Latin America. So I don't think that that's likely to be. I think the bigger issues are going to be what we're seeing in terms of these political shifts, the shifting political commitments that are having an impact on official development assistance, including for health in so many countries right now. Thanks.
So I guess we just need to wait and see what happens in the next few months. Lizzie always asks the toughest questions to our panelists. But thank you, Lizzie, for your participation. And
Yeah, hello. Hello.
Yeah.
This is Harry Alpha
ahead,
from
Harry.
Surrey. Yeah, my Q&A was how can the Global Fund support the countries to develop tools to track all of these strategies, especially when you think about the UHC and integrating the UHC into the PPR issues. These are very key. Yeah, so I really want to see how the Global Fund can support this process for us to develop tools in terms of tracking all of these interventions. These are very good. If we have actually learned so much to detect even the HIV pandemic, when reports were coming in at the health facility, we should have tracked the pandemic at an early stage before it has become global. So I really want to see how the GF is pioneering this process, and now they are leading it. So I want to see how support can be provided in countries. Just mentioning about what the former speaker was just asking is the funding landscape. And the funding landscape is one of the critical areas that we really need to look at. So I rest my case. Over.
Yeah, it's one of the questions that we addressed earlier, but maybe David, you can just repeat some of the points that you raised.
Thank you for the question. So I like to be as direct as possible, but I'm offering this to you at a personal level. This isn't an institutional position. It's not official in any way. I think that if we start by considering our core investments in HIV, TB, and malaria, we have long encouraged countries to develop and to maintain national strategic plans for HIV, TB, malaria, and for health systems. And typically for health systems, these aren't comprehensive plans, but they might be a digital health roadmap, might be a laboratory system strengthening plan, strategy, etc. So we have long encouraged countries to use those as the basis for developing funding requests and for developing grants. And we have also made those tools eligible within our grants, so countries can spend the Global Fund resources to develop those. We have not, to my knowledge, or at least recently, required that those plans exist or that they be used. An exception was in COVID, in C19RM. We did require that whatever the country response plan was, be referenced within the funding request. But I think that given where many countries are at is so variable today, that many countries have not maintained, if you will, robust strategic plans that are, the legitimate basis for programming decisions. I'll say to you that I don't think it's likely that the Global Fund would move further into a space where we as a global multilateral financing organization would be tracking country plans. I think we typically defer to either normative agencies like WHO to do that, maybe UNAIDS or Roll Back Malaria or Stop TB, some of the partnership organizations, possibly to civil society groups to do that. We haven't sought to do that. And I think for health systems and PPR, it's probably unlikely that we would do that generally. Where you might see it is, again, introduced within the application guidance as either something that is recommended or required, depending on the context, in relationship to a specific proposal. I hope that's clear. Thanks.
All right. Thank you, David. So before I go to Sotherid, I'd like to direct the conversation to Fitsum. So for the next question, I think it's David who raised this question. So he's curious if your colleagues or you are exploring the concept of epidemic-ready PHC as a modality for driving integration of PPR into UHC. So Fitsum?
Okay, thank you very much. That is very resourceful. We'll learn gradually from the process. Thank you.
Okay, thank you, Harry. Fitsum, go ahead.
Thank you very much, David, for that question. Actually, we have not been specifically going into that area of intervention. However, I was looking also to the link that you have shared already, and it's something that we can really collaborate further on. But so far, we are very much basically looking into UHC and also how communities can further influence the process, but very much also interesting to delve in that with collaboration. Thank you.
Thank you, Fitsum. So probably after this call, we'll do some reading on the document that David said. So due to the interest of time, I'll only take in the two persons with raised hands now. So I'll pass it over to Sotherid. So I hope I'm pronouncing it correctly. Just correct me. Go ahead.
Hello.
Hello. Please go ahead.
Hello, Jeff. Did you hear me?
Yes, we can.
Okay, I would like to speak in local language so that my colleague understand. And Mr. Chung is the translator here. Hello, Chung. Hello.
Chung? I think
Hello, Chung.
The Kimmer channel.
Hello, Chung. Oh, maybe he's gone.
All right, let's try to fix first the translation. Jeff, can you assist us on this? And then let's go first to Lizzie's question.
Okay.
Great. So yeah. Okay. So this one is directed to Fitsum. I know he's tackling the Lusaka agenda, and now we're talking about UHC. But Fitsum, we've seen even the Abuja Declaration or something that note actually none of the African countries kind of reached the target of having at least 15% of its national budget directed to health. So how realistic is it for us to start, pushing again with the UHC agenda? And we're seeing like a financial gap, but that gap, ideally, we're thinking the private sector will, kind of get in and fill that particular gap. Is that the angle you're also trying to look at, Fitsum?
Thank you, Lizzie, for that question. Actually, I was even thinking of the Lusaka agenda while also presenting, but I didn't want to extend it to that conversation. I think the current crisis is has given us a context on why we need to be very looking into the provisions of the Lusaka agenda, given how the Lusaka agenda implementation will be also based on the level of interpretation and the level of also contextual understanding of it by member states, Africa CDC and the EU at large. And also that also reflects into what you have raised in the already existing commitments of the African Union, such one being the Abuja 15% declaration, which according to the Africa scorecard, I think we only have one country who has achieved that. Can you hear me, RJ?
Yeah, I can hear you.
Can you hear me at all?
Yes, I can hear you.
Yes, of course.
Hello?
Yes.
Okay.
Yes, we can hear you. We can hear you.
Okay, great. I think the Abuja Declaration was a commitment of 2001, whereby HIV, TB, and malaria were declared as health emergencies in the continent, and also ministers of health and heads of states also agreed to allocate 15% of national budget to health. However, going now 23 years thereabout, we only have one country who has made that provision, which is South Africa, and the other indicators, financial indicators being the 5% GDP target and also the per capita allocation. So even we have noted some increase in most of the African countries, talking from the African continent, and that was due to the COVID-19 pandemic. So we're not even sure that the increases over the past few years will likely be the reality moving forward. However, given the context of the US funding freeze and also the timely discussion of the Lusaka agenda and also the how PABs and other elements of the pandemic treaty are being also considered in the pandemic agreement, definitely it's a timely conversation. And I think we are kind of witnessing some approaches, especially with some African countries, on how further the domestic resources will take some charge within that. The reality might kind of tell us a different story. However, it's a reality that we need to face and make sure that our domestic resources also make up or catch up to the existing gaps that we have seen. So it's not a good picture that we are seeing ahead of us, but I mean, there should be efforts that we need to be very conscious about. And some of the realities that we're witnessing might not change for quite some time as well. So I'm not sure if I addressed your question, Lizzie.
All right, thank you, Fitsum. So we'll proceed to Soterid. So apologies, we can only take in one more question due to time constraints. For those who are speaking English, hopefully you can enter the English channel so that you can hear the translation. Go ahead, Soterid. Yeah, I think you're on mute. Soterid?
Yeah. Do you hear me now?
Yes, we can hear you.
Okay, I try to speak English because I don't hear from my translator. Actually, I love the word. First of all, I would like to thank for the organizer for this event, very important event in terms of PPR response. And I love to hear the word of community engagement in all aspects of the video intervention, especially in the mention of community financing. So far, the funding support to community is less and less according to the fund decline. and various organizations that award the grant from especially Global Fund, always thinking of they are running for first before they just give very tiny amount to support the community. And my question is that, how could the voice of community bring to the Global Fund arena in order to increase or improve the mechanism of the community engagement in all the disease components? Do you understand my question, Jeff?
Maybe can you repeat the last question, like the a more concise version?
We want to see the improvement of the Global Fund mechanism to bring about the voice of community from respected country or regional origin in the arena of in the Global Fund concept. I mean that, of course, we have a Global Fund country team to visit the Cambodia, in separately Cambodia, but we have very limited time to raise the issue, to discuss with the Global Fund team in order to raise our concern to the Global Fund.
Yeah, so I think Salterid is asking on how can voices of local communities can reach Global Fund.
Yes, of course.
Yeah. So David.
Thanks very much for your question, Sodarid. So, you know, I think you're highlighting the limitations of a country governance model that is intended deliberately to bring in community voices in different ways. You're highlighting, you know, within the CCMs, the country coordinating mechanisms, and the guidance around how those should be developed in an inclusive and a transparent and a participatory way, reflecting a variety of constituencies, including community and civil society, that's not a perfect solution in all countries, that there are limitations to that. And even when the CCMs are constituted effectively and well, there can be limitations in terms of the CCM being a body that will, let's say, consistently prioritize community engagement in this example above other types of investments. I'll be honest, I don't know if there are going to be dramatic changes in our operational model in the near term. But I would reiterate, I would repeat, you know, what we talked about earlier. The more that countries appreciate, and the more that communities make the case that their unique value add, okay, from a advocacy standpoint, whether it's the type of advocacy that Fitsum is talking about, which is advocating for UHC, okay, advocating for universal health coverage and health insurance, which includes basic primary care services that are the front lines for identifying outbreaks and responding to those outbreaks, just as an example. So advocacy, focus on resource mobilization and policy, and then demonstrating those implementation roles. Now, I realize there's a catch-22 here. There's a contradiction, because to demonstrate roles in effectiveness, you need money, usually, right? And there has to be some minimum amount of money to give you that traction, but depending on the country context, knowing it, you know, there are variations and limitations. It's trying to make that case in terms of the implementation roles. And then also where you've established a CLM model and roles in monitoring, using data to monitor services for HIV, TB, and malaria, and building on those is what Copper has done. Really try to build out and expand the array of services and even systems functions that communities are structurally approaching and dealing with, and ultimately trying to support and improve in their communities. So I know that was a bit roundabout, but I hope that's helped. I hope that's helpful. Thank you.
All right. Thank you. And hopefully the committees can also co-advocate for RSSH when they engage their governments, given the inputs from David as well as Fitsum earlier. So with that, we would like to end the discussion for now. But we'd like to, of course, share this question. So hopefully you can participate in our WhatsApp community. So later I'll show you the QR code where you can join the WhatsApp committee so that we can sustain the conversations. And then I'd also like to present this certificate to David Lawrence for his efforts in giving us a very thorough lecture on RSSH and PPR, as well as to Fitsum Laku, who shared us the committee guide for UHC. So maybe we can get a photo of everyone who joined us today. So if you're comfortable, you can turn on your cameras, and then Jeff can take the photo.
Yeah, I just want to know if you are getting me, Harry from Sierra Leone.
Sorry? Can you repeat?
Yeah, I just want to know if you're having my photo because I'm using my phone, but my camera is on.
Ah,
We can see you. We can see you. Thank you.
Oh, okay, okay. Thank you. Thank you.
all right.
Photo now. We have 3 panels. So this is the first one. Put on your best smile. 1, 2, 3. Second one. 1, 2, 3. And last panel.
Can you
1.
see my
Yes,
can you see my photo, Jeff?
yes.
Good.
All right. Back to yours.
All right, thank you. Nice to see familiar faces as well from our previous participants. As before, I'd like to invite you to answer the Webinar 7 evaluation form. So you can scan this QR code and also follow Upcaso and Act Africa for the recordings of the webinar as well as the summary of the session.